I think pretty clearly in that talk the focus will be on post-operative evaluation, but I don't think we should forget preoperative evaluation. And what do I mean by that? Well, we're talking about cases, I think, that have advanced OA, bone-on-bone changes, and the reason I'm bringing that up is that clearly I'm seeing a focus even in my own practice in patients that have received total knee arthroplasty with really not what I would consider radiographic bone-on-bone changes, but somebody's done a scope, has shown an area of some cartilage degeneration, and then someone's gone ahead and done a total knee replacement. And so if I present this case to you, this is a patient that had 3 years following a left total knee and 1 year following a right total knee, had done great on the left side, they went ahead with the right, and the right side has been sore ever since the knee was done. It really did not improve the symptoms at all. And, why is that right knee doing so poorly? There's the preoperative radiographs, and I won't disagree, there's a little bit of arthritis on that lateral side, but where there's a lot of arthritis is in that patient's hip. And so this patient had a total knee, and even in Canada, you can't do a total knee replacement for hip arthritis. It's not going to work. So this patient continued to have ongoing pain, and simply because the surgeon, went ahead and did a bilateral total knee. So that's preoperative. What do I look for when assessing postoperative films? 3 things I'll touch on: limb alignment, balancing, and then component alignment and orientation. So limb alignment, I think we can all agree what we're aiming for is that mechanical axis from the center of the hip through the center of the knee through the center of the ankle. That's the dogma. That's what we've all been trained on. And does it have to be perfect? Well, hopefully not, and the answer is no. In a very interesting paper, Mark Pagnano from the Mayo Clinic has looked at 400 total knee replacements at 15 years. A group were within 3 degrees plus or minus, and then there was a group that were outside of that 3 degrees, and he showed no functional differences and no outcome differences in terms of longevity. Now, we're not advocating a malaligned knee, but by the same token, is it 3 degrees, is it 4, is it 5? I don't think the evidence is entirely that strong. With respect to balancing, what I look for, even on an initial postoperative film, and I agree with Anil, you want weight-bearing films ultimately, but even on an initial postoperative film, I think you can see that on your left, that's correct. The femoral component and the polyethylene are congruent with one another on both the medial and lateral compartments. On the right, you can see that was a valgus knee, and the surgeon didn't quite get it right. It's lifting off a little bit on that medial side, and so I look for that for balancing. Additionally, there's some authors that have said to us that minor joint line elevation is a bad deal, and patients functionally won't do that well. Well, I would challenge that dogma. In fact, we looked at a series of 200 total knee replacements that had variations in joint line elevation with no functional differences, no clinical outcome differences, and no longevity issues. And the issue is really, and we're going to talk about this all meeting, I think, is you've got to get the knee balanced in terms of flexion, extension, gaps, but occasionally that joint line will be up 2 or 3 or even 4 millimeters with no apparent functional limitations that can be demonstrated. With respect to the components themselves, we know that component malposition has a lot of consequences with increased pain, potential for range of motion, functional issues, and potential for failure rates. So I'm going to take through for about a minute each one: femoral, tibial, and patellar component. The femoral component malposition can occur in all planes. If we start with the sagittal plane, we're aiming to have it parallel to the long axis with the resection at the anterior cortex. That being said, if you're critical, many knees go in slightly flexed, and if it's significantly flexed, you can decrease your range of motion by creating, if you will, a fixed flexure contracture, and that can create anterior or extensor mechanism pain. Anteriorly translating the component occasionally occurs by surgeon not trying to avoid notching it, but if you exaggerate that, you can overstuff the patellofemoral articulation. I think that's a real entity, and that can create pain and decrease range of motion, in this case flexion. I think notching, we've all been aware of. Interestingly enough, small notches I don't think create a significant problem. A significant notch obviously looks terrible radiographically, but if you overdo it, you can create a tight flexion gap if you're not subsequently balancing that knee and decrease range of motion. The coronal plane, we all agree, is going to be in that 6 to 7 degrees of valgus to the anatomic axis with middle to slightly lateral positioning. If you medially shift your component, that can result in patellar instability, so you avoid that. It's hard in a revision, but in a straightforward primary, that's not that hard to avoid. Varus valgus, I think, is uncommon for us to get that wrong. If we get it significantly wrong, that can lead to increased wear and pain. The rotation is probably the most challenging aspect. We're looking to have it 3 degrees of external rotation to the posterior condylar axis, and while that's reasonably easy to achieve, I think in most varus knees, it's difficult in a valgus knee when you have a hypoplastic lateral condyle. You put the jig on, it's going to spin it internally rotated, so you have to change and correct for that to get your external rotation. With respect to the tibial component, the goal is 90 degrees to the long axis of the tibia. Malalignment can lead to excessive wear, and that's been demonstrated over and over again. So the goal has to be to achieve appropriate alignment, and slope is an issue that we can talk about in the discussion, because some of us aim for a 3-degree slope, even in a PS knee, and others are 0 degrees, some difference in a PS versus a CR. If you increase the tibial slope, that can lead to flexion gap instability, and if you decrease the tibial slope, you can pinch off your flexion gap, and particularly with a CR knee. Component orientation, rotationally, it should be that medial 1/3 of the tibial tubercle, and if you get that wrong, that leads to patellar maltracking and also potentially patellar instability. And lastly is the patellar component. The goal is to have it central or slightly medial. A common error, if you touch it over laterally, you can lead to patellar instability. So in conclusion, what to look for radiographically? If you see a patient that's got a stiff knee, look for oversized implants and an overstuffed flexion gap. Too little tibial slope can also create stiffness. You see it more in a CR versus a PS knee. Instability, look for undersized implants with a loose flexion gap. Too much tibial slope can also produce instability. And lastly, each x-ray correlate with a patient's pain. Things like an overhanging implant can create focal point tenderness that I've seen in patients that can be addressed with a revision surgery if necessary, if non-operative treatment can't create that cure. So in conclusion, beware of and avoid common component malposition errors to maximize the results you get with your total knee replacement. Thank you.